Good morning. Today we're going to talk about dysnatremia as part 1. Specifically, we're going to focus on hyponatremia. First off, just a review from the previous video that any change in water is going to equal a change in serum sodium. Alright? So any change that we have in our salt is really going to be a change in our water content. For serum sodium to decrease, we're going to need two things to occur. One, we're going to have a defect in our urine diluting ability. Specifically, we're going to see at the kidney when we talk about that later. And two, we're going to have excess water intake, which is fairly rare and we only really see in primary polydipsia and maybe in bare potomania. The vast majority of the time we'll see a defect in urine diluting ability causing hyponatremia, and this is normally going to be a water problem due to ADH release. So it's important for us to remember that anytime we have hyponatremia or decrease in our serum sodium, there will be an increase in total body water no matter what. Now, total body sodium can be increased, stay the same, or decrease, but whenever we have a little serum sodium, the total body water will always be greater than the total body sodium. So let's start with a clinical example. 20-year-old male that drank 10 liters of water during a challenge from his roommates. How does his body maintain homeostasis in regards to his serum sodium? By maximally diluting his urine. So in the kidney, we have three major requirements in order to maximally dilute our urine. The first happens in the proximal tubule and hence throughout the rest of the kidney. Essentially, that's maintaining adequate GFR to deliver tubular fluid to the diluting region of the kidney, which we stated was starting at the thick ascending loop of Henle before. Second, we need reabsorption of solute in the diluting region. And that's going to be in the thick ascending loop of Henle thanks to the sodium potassium 2-chloride cotransporter. And lastly, we need impermeability of the diluting region to water. And this happens when there is no ADH release. So anytime ADH is released, we lose that impermeability, and we're not able to maximally dilute our urine. Next, let's quickly look at some disorders that can cause hyponatremia and have problems with urine dilution. First, as you notice, most of these disorders have decreased fluid delivery due to decreased volume. And lastly, there are a few, such as diuretics, which cause decreased solute reabsorption by the diluting segment. And finally, the vast majority have issues with ADH. Now moving on to serum sodium and osmolality. Osmolality is equal to 2 times sodium, roughly. So anytime you see low sodium, you should think there is a hypoosmolar state. That's what we call true hyponatremia. A question we commonly get from students is, can you get hyponatremia without low serum osmolality? Plasma osmolality is equal to 2 times sodium plus the BUN divided by 2.8 plus the glucose divided by 18. So normally when plasma osms go up, you expect that urine sodium should go up, as they're pretty much interchangeable. But occasionally we will see plasma osmolarity go up while there's a decrease in our serum sodium. And normally this is going to be due to an increase in our glucose, as you can see in the arrows below. We call this translocational hyponatremia. As you can see here, we have our ECF, which is 1/3, and our ICF, which is 2/3. And we can see that normally when there's no hyperglycemia, we have an equal amount of water on both sides. Now, when a patient becomes hyperglycemic, which we commonly can see in diabetes, we have an increase in glucose on one side, and since no insulin is present, it's not able to cross the semi-permeable membrane. So now the water on the right side, the intracellular fluid side, decreases while the sodium on the left side increases. This makes it look as if there's a significant and real hyponatremia, but what we're actually seeing is a shift of water from compartments. between compartments. So there's actually a way we can correct for this. And there's two methods. The first is CATS. From the CATS method, in the study he did, he found that there's a 1.6 decrease in serum sodium for every 100 in glucose over 100. While Hillier, in a later study, found that on average it's about 2.4 for every 100 over 100 in serum glucose. So next, what if we have hyponatremia with a normal serum osmolality? This used to be somewhat common when we use flame photometry to measure serum sodium. And this happens anytime there's an increase in the solid phase of plasma. And we can see this when we have an increase in lipids or proteins. As you can see in this diagram here, that normally the plasma volume is being measured for serum sodium. That includes the plasma water as well as the plasma, as far as the lipid volume and protein volume. So anytime we have an increase in that protein or lipid volume, it makes the plasma water volume look like less, and ultimately makes our serum sodium look like less. But there's actually no decrease in our serum sodium here, and we call this pseudo hyponatremia. Now let's move on to a clinical question. We have a 57-year-old male with a history of cirrhosis who is found to have a serum sodium of 127, with the normal being 135 to 145. He has anasarca and has ascites. He is complaining of muscle weakness but is awake and oriented to person, place, and time. His blood pressure is 95/60. His serum osmolarity is 262, which is low. His urine osmolarity is 155, and his urine sodium is 10. How would you describe his overall clinical volume status? Is it A, hypovolemic, B, euvolemic, or C, hypervolemic? The correct answer is hypervolemic. This is because the patient has an increase in his total body sodium. But because this patient is hyponatremic, we know that he also has an increase in his total body water, which is going to be greater than his total body sodium. Next, the question is ADH being released? And we can look at his urine osms to see that. So anytime you see urine osms that are greater than 100, we can assume that ADH is being released, and that water is being absorbed as we're able to concentrate the urine. Next, there are two reasons ADH will be released. First is as the osmolarity or tonicity increase, which we do not see here. And secondly, is the effective circulatory volume decrease. And that's likely the correct answer here. One of the ways we can know that is by looking at the urine sodium. If the patient's in steady state and he has a decrease in his effective circulatory volume, we expect that he should have an increase in his renin. This is going to then lead to an increase in his angiotensin II, which is going to promote proximal sodium reabsorption. And also this is going to cause an increase in his aldosterone, which is going to promote an increase in distal sodium reabsorption. And so because of this, we expect the patient to have a low urine sodium because he's reabsorbing sodium proximally and distally. So next case, let's look at a gentleman who happens to be a 42-year-old male with a history of hypertension that is found to have a serum sodium of 120. He has dry mucous membranes and skin tinting. He is confused and isn't sure where he is, but reports that he got lost camping 4 days ago and had diarrhea after drinking water from a pond. Alright, so next, his blood pressure is found to be 89/59 with serum osms 250. His urine osmolarity is 265 with a urine sodium of 5. How would you describe his overall clinical volume status? You see A, hypovolemic, B, euvolemic, or C, hypervolemic. So this one should be pretty straightforward. This patient is pretty hypovolemic, as you can tell by his low blood pressure and his exam. So this patient being hypovolemic has a decrease in his total body sodium. And because he's hyponatremic, we know he has an increase in his total body water in comparison to his total body sodium. The next question is ADH released again? Let's look at his urine osms. It's 265. We once said before that anytime the urine osms are greater than 100, we can assume that ADH is being released, and the patient is able to concentrate his urine in order to reabsorb sodium and water. Alright, so next two questions are, why is ADH released? Are his osms up? No, he has hyponatremia. So that's not the cause of ADH release. So next we have to think about his effective circulatory volume. As we stated before, his overall volume status is likely hypovolemic. So we suspect that his ECV is going to be down. And we can verify that if this patient's in a steady state by looking at his urine sodium. His urine sodium is 5, which tends to be fairly low. So we can deduce that this patient has an increase in his renin due to decreased effective circulatory volume, which is then going to lead to an increase in angiotensin II, which is going to help us promote proximal sodium reabsorption. And then we're going to have an increase in aldosterone, which is going to promote distal sodium reabsorption. Together, these are all going to help lower his urine sodium so that he can resorb it and increase his blood pressure. Alright, let's look at another case. It's going to be a 69-year-old female with a history of small cell carcinoma of the lung. She's found to have a serum sodium of 130. She has moist mucous membranes. She feels fine and denies any symptoms or complaints today. Her blood pressure is 128/82. Serum osms are 269, which is low. Urine osms are 390. And urine sodium is 25. How would you describe her overall clinical volume status? Is she A, hypovolemic, B, euvolemic, or C, hypervolemic? Answer this time is euvolemic. Patient appears to have normal blood pressure and no symptoms. Her total body sodium in this case is pretty much unchanged, but her total body water is increased in comparison to her total body sodium, hence why she has hyponatremia. Next question is ADH released? And again, we can look at the urine osms. We see that there's 390, which is elevated. Again, anytime the urine osms are greater than 100, we know that we're able to concentrate our urine and reabsorb water. So let's find out why ADH is released in this case. So first, the question is, are her osms increased? Nope. So we realize that's not the cause of ADH release. So secondly, we want to check on her effective circulatory volume. Is it decreased? In this case, it is not. She has normal blood pressure, moist mucous membranes, and no signs that she's hypovolemic. So in this case, her release of ADH is inappropriate. Her urine sodium is actually normal. It's not decreasing the setting. And if we think about what her renin is, in this case she has a normal ECV, so she does not have increased renin, so she won't have an increase in angiotensin. So there's going to be no reason for her to reabsorb sodium in the proximal convoluted tubule. Also, because there's decrease in the RAS pathway, there's going to be no release of aldosterone, so we're not going to have distal reabsorption of sodium. So this actually happens to be the syndrome of inappropriate ADH, or SIADH as it's commonly known. And this can happen for several reasons. It can be due to neuropsychiatric disorders, It can be due to pain with or without narcotics, as that's been found to cause it. It can be due secondary to medications. It's too many to name here in this course today. It can be due to ectopic tumor production, which is the case here in this patient. And it can also be due to pulmonary disease. So now let's take a step back and try to organize what we've learned so far about hyponatremia. So the way I like to think about it is to branch it into 3 points to start off. One is a hypoosmolar or hypotonic, isoosmolar isotonic, or hyperosmolar or hypertonic, with hypo being the true form of hyponatremia. And with this, the 2 questions I want to know next are, is ADH suppressed, meaning or my urine osmolarity less than 100? In that case, it's normally due to 3 conditions: primary polydipsia, beard potamania, and tea-and-toast diet. Primary polydipsia is going to be from an excess of water intake. We're drinking more water than we can actually excrete in a given period of time. Beard potamania is going to be a decrease in solute taken in and an increase or excess of water taken in. And tea and toast diet is simply going to be a decrease in solute taken in. So those patients are still drinking an adequate amount of water, not too much, but they're just not taking in enough solute to increase their serum sodium. Next, the question is, if ADH is released, which we see from urine osmolarity greater than 100, what's the volume status? The first is, if it's hypovolemia, it's likely going to be due to GI losses or renal losses, and diuretics, which is also another form of renal losses. The next question is, if the patients are euvolemic, I want to know, is it due to renal failure, cortisol deficiency, hypothyroidism, or is this due to syndrome of inappropriate ADH release? And lastly, is the patient hypervolemic, meaning they have an increase in total body sodium, but they have a decreased effective circulatory volume. And we see this with CHF, cirrhosis, and nephrotic syndrome. So what are some of the signs and symptoms of hyponatremia? Most of the signs and symptoms tend to be neurologic in nature. And they include lethargy, disorientation, muscle cramps, nausea, anorexia, agitation, abnormal sensorium, depressed deep tendon reflexes, changed Stokes respirations, hypothermia, and seizures. So why do these problems actually occur? Initially, in the brain, there are going to be solutes, specifically sodium, potassium, chloride, and osmolytes, in balance with water. When the patient becomes acutely hyponatremic, there tends to be an osmotic shift, with water entering the brain, which tends to be hypertonic compared to the vascular space. This is a little different from chronic hyponatremia, in which the patients have a decrease in water over time back to near normal states. And so there's a fair balance of water in the brain cells versus outside of the brain cells. And there's also similar composition of osmolytes and sodium, potassium, and chloride in the brain versus outside the brain. So the problem with chronic hyponatremia comes when you actually treat it. If patients are treated too quickly because they have a decrease in intracellular osmolytes, these patients can have a shift in water from out of the brain to the extracellular space. And when that occurs too quickly, these patients can suffer osmotic demyelination. So now I'm quickly going to touch on the basic principles of treatment for hyponatremia. So as far as the basic principles go, if it's acute hyponatremia, you can quickly correct it, as there hasn't been a change in the osmolytes yet, versus chronic hyponatremia, where there's been a change in osmolytes. So you have to slowly correct it to avoid osmotic demyelination, as we showed in the previous picture. So also, it depends on a specific type of hyponatremia how you treat it. If it's hypovolemic, the answer is going to be to give more sodium. And this is going to be in the form of saline the vast majority of the time. If it's hormone insufficiency, it's going to be replaced to hormones. That's going to be cortisol and thyroid, depending if the patient has adrenal insufficiency or hypothyroidism, respectively. If the patient has SIADH, treatment of choice is going to be water restriction because these patients have a consistent release of ADH. Also, with hypervolemic hyponatremia, it's a similar treatment. These patients tend to have a decreased effective circulatory volume. So these patients will need to avoid excess water.